All right, I thought while we were waiting for some more folks to join, I was gonna put a few fertility facts together, just some fun little fertility trivia that I'll put up here. And if anybody wants to take a stab at the answer, you can feel free to put your best guess into the chat or into the question and answer box. Okay. So again, while we're just waiting a couple minutes for people to join, a very common number that we're often talking about as we discuss, reproductive physiology with patients and with each other is, regarding how the ovarian reserve, or the number of eggs, changes over time. And so the first question is, how many eggs does an ovary contain at birth? And I think an important thing that I always explain to patients is that the ovaries are very unique in their function. The eggs are cells that don't regenerate. There's no new eggs that are developed after somebody's born. And that's, kind of the primary issue that we're often facing when it comes to reproductive health and fertility. And if I have a 35-year-old patient in front of me, I tell her the eggs that are, within her ovaries are 35 years old. They've been there, for her entire life. And that's completely different than sperm. Sperm is produced in the testicle. It's constantly making new sperm. That's why, male fertility stays relatively stable, even into someone's 40s, 50s, 60s. But with the eggs, it's a different story. 35-year-old cell becomes a little fragile, and at that point we start to see some quality decline. So anyways, how many eggs does an ovary have at birth is around approximately 1 million. And then we see a decline in that number until the time of puberty. There's about 100,000 at that time, and then a few hundred eggs lost each month until the time of menopause, which on average is about age 50, when there's very few eggs remaining. Okay, what year was the first IVF conceived child born? So basically, how long has this fertility treatment technology been around? Our kind of simpler treatments, Clomid, ovulation induction has been around a little bit longer, but IVF really revolutionized the field, and our field has, of course, grown rapidly since that time. And so, early attempts were, very, very unsuccessful, very, difficult time setting up the proper culture conditions, timing everything just right. There was an incredible amount of time and effort and patients, going through these treatments before finally there was success achieved. And the first birth was 1978. Now there's two B options on there, but it's the second B, 1978, and that was in London. And then shortly after, that came to the United States. Another treatment that we're often discussing with patients, or patients will come to talk to us about, fertility preservation, before they try to conceive, to help increase their chance of being successful in the future if they have infertility. But for a long time, this technology also, was being developed. Success rates were not where we wanted them to be. And so it was experimental, and really was only done under research studies for quite some time. And then eventually, things were sorted out. Success rates improved significantly. And that experimental label was removed finally in 2013, actually. So it's really been just a little bit over a decade. The main change that occurred was how we were handling eggs when we froze them. We changed the process so that the eggs ended up being much more successful. They were much easier to survive the freeze and thaw process. And so patients had a higher number of eggs that they were able to use after going through that process. That's what we call vitrification. That's how we handle eggs and embryos that we treat in our current protocols. But it's really only been for about the last decade that we've perfected that particular technology. So as you'll probably know and see, lots of things in our field are constantly changing and advancing, and our success rates, have dramatically improved, really, even in the last 10, 15 years. It's quite incredible. So it's a very enjoyable and rewarding thing to be able to see and be a part of. Okay, so I think it's 5:36, so we'll plan to go ahead and get started. So I'll introduce myself. I'm Dr. Phillip Romanski. I'm one of the REI physicians here at RMA of New York in New York City. I have a few roles here other than just clinically, seeing patients with infertility or for fertility preservation. I'm also the associate research director for our entire fertility network, and we help to perform, some of the largest and leading studies in our field to push the science forward. And so we're really proud of those efforts. And I'm also the associate fellowship director for our REI fellows, who spend 3 years with us training how to be a reproductive endocrinologist themselves. And I'm excited and really happy to be talking with you all today about Fertility 101, or talk I titled Fertility Basics, what you need to know, before you get started. And we're gonna, go through a few different areas that I think are really the important things that all patients should know before they start trying to conceive. And then, when things are becoming difficult, what those next steps look like. And then we'll save some time at the answer for, any questions that you might have. So feel free to, if anything comes to mind, just you can put that in the Q&A, and we'll go through that a little bit at the end of the talk today. So, before somebody starts trying to conceive, this is a part of the process that I think often gets overlooked by patients. They're ready to start building their family, they're eager to get going, and then, they kind of just get started. But just like anything, planning and preparation is really important to be sure that everything will, go as smoothly as it can, and that any potential barriers, can be addressed early on in a safe way. And so these are, I think, really important things that everybody should know, before someone starts trying. It's really important to meet with an OBGYN or, reproductive health provider, just to review, what those plans are and what that might look like for somebody. It's important to review, someone's medical history to determine if there's anything in the history that, might make the pregnancy higher risk, might make it more difficult for that person to conceive. Perhaps, some medical conditions might need to be optimized or reevaluated before somebody, safely is able to get pregnant. And in addition to that, kind of reviewing the medications that somebody might be taking. Of course, certain medications, many medications are safe in pregnancy, but some of them are not. Some of them are known to be harmful. And so it's important to kind of review that and understand what's safe, what's not safe. And then, talking about, any important supplements that somebody might need. Prenatal vitamin being the most obvious one. And there's, lots of different options for a prenatal vitamin. The most important thing in that is the folate or the folic acid, but there's some other really important nutrients in that vitamin as well, many of that which are already, received in the diet, but that's important, and actually has some benefit to start the prenatal vitamin a month or two before somebody starts trying to get pregnant. That can help to improve some of the pregnancy symptoms, particularly the nausea symptoms, are better if somebody starts that prenatal vitamin on the earlier side. Going through the reproductive history is really important. Has somebody had, procedures or surgeries on the uterus in the past, a history of difficulty getting pregnant, a history of, pregnancy loss. These are all things that are helpful to know ahead of time. Reviewing the family history is a critical step. Sometimes there's, very clear genetic conditions that may run in somebody's family, or sometimes, I'll identify a strong family history of cancer. That also could be genetic. Anything, that could be passed down in the family has a reproductive risk, because that could be passed down, to the offspring. And so we often will do screening for those conditions. And sometimes patients ask, why is this important for my fertility? And the main reason is, if we can identify a specific genetic mutation, then we do have the option of, specific treatments like IVF, where we make embryos and then test the embryos to see if any of them have a specific mutation. And in that way, we can identify which embryos to transfer, which ones are healthy, and which ones might have disease, and avoid passing it down in that way. Going through social history is really important as well. The main things I speak to patients about is their lifestyle, because that's really the one kind of the one thing, or one of the main things that somebody really has control over. Most other medical history, family history is out of your hands, but social history is one area where people can make a lot of headway. And there's no specific intervention that's going to make or break the success for somebody. I always say that any decision that you make that's good for your overall health is going to be good for your reproductive health. And so obviously that means no tobacco, no drug use. These things are harmful for fertility. Alcohol use, obviously during pregnancy, that's harmful. While somebody's trying to conceive in high amounts, it reduces fertility as well. It's not something that has to be cut out completely while you're trying to conceive. Optimal amount of alcohol would be 3 drinks a week or less. A lot of people will cut it out completely just to to feel comfortable, and that's completely fine. But a drink here or there is okay, and that's true for both male and female fertility. Caffeine is another thing that comes up very commonly. A lot of people cut that out too, because that you always hear or read about the harmful effects of caffeine in pregnancy. But also that's really only true for caffeine and really high amounts. Moderate, smaller amounts of caffeine have been shown to be safe. And so those doses are about 200 milligrams of caffeine a day, which roughly translates to a cup of coffee a day. So I tell patients, if you want to have coffee, it's fine. 1 cup a day is okay. It's also fine if you want to just cut that out completely. And then diet is another common thing, that we talk about. There's no specific food, that's going to help somebody get pregnant or not, but it's the same idea. Focus on a healthy diet. Healthy diet, fresh foods, fruits, vegetables, fish, those things have all been shown to be beneficial for fertility. And really the main thing to focus on is trying to avoid or limit processed foods as much as possible. Definitely there we see a harm or a negative impact on reproductive outcomes. So those are the main lifestyle, kind of social things that somebody should really focus on when they're getting ready or trying to conceive. And then, of course, there's some blood tests that are really important before a pregnancy. Kind of the biggest one down at the bottom, the genetic carrier screening here. That's a blood test that's recommended for anybody before they get pregnant, looking at gene mutations that might be there in your DNA. In the DNA, there's 2 copies of every gene. And for most conditions, as long as at least one of those genes is normal, you'll be healthy. You're not going to have a particular disease. So that other copy could be mutated. You would never even know it. But what's important to find out is if you and your partner have a mutation in the same gene, that's when both mutated copies could get passed down to the child, and that child could have a particular disease. So that's a blood screening test that we often do. And when we identify a shared mutation, which is not common, we see it about 1% of the time, but we have the same option of doing IVF, testing the embryos to find out which ones have disease and which ones don't. And then we pass down the ones without, and transfer the ones without. So that's sort of a pre-pregnancy visit. Now, when somebody's, again, trying to conceive, it's important to understand how to do that. There's a very narrow time each month that pregnancy is possible. And so this is just an overview of the menstrual cycle and what's going on during that period of time. So let's assume somebody has a regular 28-day cycle. At the top here, you see all of these different hormone fluctuations that are occurring throughout the month. And if you're somebody that's ever kind of tracked these things, there's so many different apps and at-home consumer kits these days. You can kind of interesting to see what's going on, during the cycle. But the important thing that I want to point out is it's right around the middle of the cycle, usually around day 14, where you get this big spike here in a hormone called luteinizing hormone. That's the hormone that's required in order for ovulation to occur, in order for the follicle that's in the ovary to rupture and to release the egg. And so if somebody's doing ovulation predictor kits, that's what it's looking for. It's looking for that big LH surge, and then within about a day, that egg is going to be released. Now, this is important to time or to understand, because once that egg is released, it can only fertilize for about 12 to 24 hours. On the other hand, once the sperm is in the reproductive tract, that sperm is healthy and active for about 3 to 5 days. So that's why we always recommend, intercourse in the days leading up to ovulation, because we want that sperm to be there ready and waiting, so that when that egg is out there with that short, narrow window of time, the sperm is already ready to meet the egg and to fertilize it. And this kind of shows you what success rates look like in the days leading up to ovulation, with day 0, being the ovulation itself, and and the probability of pregnancy based on intercourse timing. So you can see it's kind of the day 3 days before, 2 days before, the day before. That's really the ideal time for that sperm to be there once the egg is released. The day after ovulation, the success rates basically go back down to 0. And so that's the importance of timing. So if somebody has a 28-day cycle, we know they're ovulating on day 14. Usually I recommend start, having intercourse every day or every other day is fine on day 10, then day 12, then day 14. You're going to be capturing the window every month if you do that. Day 1, by the way, is the first day of full flow bleeding. So you just kind of count that as day 1 and then sort of track out from there. Some people, more specifically want to monitor exactly when that surge is occurring or exactly when the ovulation is occurring, just to time everything right. And so that's where you get, again, the urine test with the ovulation predictor kit, looking for that spike in luteinizing hormone. That's a good one, because then you haven't ovulated yet, but it's about to happen, and that's a good time to have intercourse. Another common one is the basal body temperature. I think the, Aura ring, I see a lot of patients wearing that now, different ways to kind of track temperature. And that's actually pretty accurate too. The only thing is that the temperature changes after ovulation. So it's not a good way to determine when to have intercourse, but it is a helpful way to say, okay, my temperature has changed now. And you can see, ovulation is this green bar here. Sorry, green bar here. And then the temperature changes after. So once that temperature changes, okay, probably ovulated yesterday. But it's not good to tell you when to have intercourse, just that the ovulation had occurred. These things drive some people crazy, though, by the way. So I don't really stress them too much, only if for somebody that really likes more data, they're kind of interesting. But for some people, it really kind of puts a lot of pressure and stress on the whole situation. So that's why with a regular cycle, 28-day cycle, you can usually know about when you're going to ovulate, and then you can just have intercourse in the days leading up. And for most people, that will be successful as long as the cycles are regular. So I don't think, tracking this is super important unless it's something that you prefer to do. So, when does somebody need to think about having a more formal fertility evaluation, completed? Well, we think about infertility as, the inability to be, successfully pregnant based on either medical, sexual, reproductive history. So it's kind of a very broad definition. But generally that sort of captures, evaluations recommended for, a heterosexual couple after 12 months without a successful pregnancy, without a ongoing pregnancy, for women under the age of 35. Okay, that's when egg quality is at its best. And for those folks, we recommend trying for 12 months. If not pregnant, then that's a good time to see a fertility specialist to see, look a little bit deeper, figure out, what's going on there. At age 35, egg quality begins to decline. Time becomes, a little bit more urgent. Certainly no emergency, but more urgent. And so we have a sort of a shorter threshold to refer a patient in, and that's usually after 6 months of trying for patients 35 and older. And then beyond that, once somebody is 40 years and above, really, we want them to be seen for a fertility evaluation right about the time when they want to start trying to conceive, because the egg quality is declining so much at that point. We want to be able to pick up anything that we can optimize, any abnormality early on. And if not successful in the first few months of somebody trying on their own, they really should be thinking about fertility treatment options to give them the best chance at being successful. Of course, other times that somebody should, come in right away would be if there's a history of irregular cycles or no periods at all. That person's not releasing eggs. Usually they're not ovulating. So you're not really able to track when to have intercourse. And that person often needs treatment to be successful. Of course, same-sex couples or single individuals will often come talk to us about options to conceive, of which there are many. And then those with known genetic diseases will do IVF, and again, we'll genetically test the embryos before we do the embryo transfer itself. So for anybody kind of meeting that criteria, once they come into the office, we go through their history in great detail, and then the first thing is just to do a fertility evaluation. So for the fertility evaluation, I explained that we're just evaluating the reproductive axis here. And so this is a picture of what's going on anatomically each month when somebody is trying to conceive. Okay, so this is a portion of the uterus here. This is one of the fallopian tubes coming off the top. There's, two tubes, one on each side. And then the tube just drapes right on top of the ovary here. Within the ovary, this is where all the eggs are contained. Each egg is in a structure we call a follicle. So you'll hear me use that term a lot, follicle. And what you see is on this ovary, these are all little follicles. It's just showing that the follicle grows for that first half of the period, for the first half of the cycle for about 2 weeks. And then eventually the LH surge happens, the follicle ruptures, and it releases the egg. Okay, the egg is just sort of free floating outside the ovary, and then it has to get picked up by the fallopian tube. So these little fimbria, these little hands here of the fallopian tube, grab the egg, pick it up into the tube, and it's usually within the tube, if there's sperm there, where the sperm will meet the egg, fertilize to create an embryo, and then actually the embryo moves back through the tube for a few days, and it tries to get inside the uterus in time to implant in the wall there and develop into a successful pregnancy. So when we're looking for causes of infertility, we're just evaluating this whole axis to see, are there any barriers here that are making this process more difficult? So one thing we do is evaluate the uterus itself. We look inside the cavity to see, are there any structural growth problems like fibroids, which is like a ball of muscle, polyps, which is just a little benign tissue growth, scar tissue, anything like that inside the cavity of the uterus is interfering with where that embryo is trying to implant and can make it a lot more difficult to get pregnant. So that's one thing that we look for. The next thing is, are these tubes open? Sometimes there'll be scar tissue or a tube is blocked for one reason or another. And in that case, the sperm can't get out through the tube to meet the egg, or vice versa, the egg can't get back to get inside the uterus. So there's an imaging test that we'll look at that's important to look to make sure the tubes are open. Another part of the evaluation is an evaluation of the ovaries, to look at them to make sure they're normal in appearance, that there's not large cysts that are causing issues with fertility, to look at the ovarian reserve, which is the number of eggs that somebody has. And we'll talk about how that impacts fertility a little bit. And then finally, what does the sperm look like? Is there enough sperm there to meet the egg? Does the sperm look healthy? Is it motile? Is it swimming around? Or are there issues with the sperm where probably it's not even getting to the egg in the first place? And that's really the main components of the evaluation. So when we look at the uterus, we often do something called a saline sonogram. This is what a uterus looks like here. This is the uterus here. The black is saline. That's basically water that's being injected into this uterus, and it's separating the top wall from the bottom wall and gives us a really clear view of what the shape of this cavity looks like. And this one looks very nice, smooth and round. There's no abnormalities there. That's what we hope to see. Sometimes the cavity can be misshapen, it can be small, or it can have structural issues. This is an example of a polyp. You can see obviously a large protrusion into the cavity. That's something that would need to be removed. Sometimes scar tissue like this, that's connecting the walls together. Okay, these things are problematic for fertility, and we would need to do a procedure to repair that, get the cavity back to normal, to get the success rates back up to where they should be. The tubal evaluation is another imaging test, often called a hysterosalpingogram or an HSG. This is a test that's done with an X-ray where contrast is injected into the uterine cavity. This is the cavity right here, this triangle shape. And then pictures are taken while the dye spills out both of the tubes. And this is a normal looking X-ray here. These tubes are nice, long and thin, and the dye is just starting to spill out both ends. Sometimes we find that the tubes are blocked and dilated, like you see on the right side here. Again, with the blockage, the sperm's never going to get out to meet the egg. So this is something that needs to be treated surgically, or possibly we need to do IVF to bypass the tubes completely. When you start Googling these different tests online, the HSG is one that you might find, people talk about it being a little bit uncomfortable. The test itself is relatively straightforward, but sometimes its contrast causes the uterus to cramp and contract. And so that's something that some patients will experience. For some people, it's pretty mild, but others, it can be pretty intense. And so we often recommend taking, some ibuprofen for a test like this, just to help prevent those symptoms. The next part of the evaluation is looking at the ovary. This is what an ovary looks like on the ultrasound. You see right ovary, left ovary, and then these black circles on the ovary. These are antral follicles. Each follicle has an egg. Within this ovary, there's tens of thousands of follicles, actually. Most of them are microscopic. You cannot visualize them. But every month, the ovary is continuously recruiting a group of them to start to develop. They begin to enlarge, and then we can see them. The reason why the number is important is because the more eggs somebody has, the higher their ovarian reserve, the more follicles the ovary recruits at any given time. And so by looking at and counting that number, it correlates fairly well with the overall number of eggs that are remaining. And then these follicles produce a hormone called anti-Müllerian hormone, AMH. That's a blood test that you often hear about, and that's an easy thing to test. That also correlates with the ovarian reserve. And this is showing you a chart of, kind of the mean and median AMH levels based on year of age here, stratified across the bottom. And what you see is that decline, like we talked about. No new eggs are produced. Over time, there's a decline in the number of eggs, a decline in that AMH level until the time of menopause, where it's very low. The ovarian reserve, the AMH is important. It's nuanced. It's not a low reserve means infertility, high reserve means very fertile. It doesn't work that way, because it's just telling us the number of eggs that somebody has. What really predicts fertility is the age of the egg, or the age of the individual. Somebody 32 years old, that's when egg quality is still very, very good, with very low reserve, should have very good fertility, the same chance to get pregnant as any other 32-year-old, because again, they're just releasing one egg every month. So it doesn't really matter what's remaining within the ovaries. But sometimes this testing is helpful if we do find it's abnormally high or abnormally low. Sometimes it can suggest some other conditions that do play a role with reproduction, or maybe if it's really low, it might suggest a shortened, reproductive lifespan. And so that's an important thing, to talk about. What that test tells us and what it doesn't tell us. The other way we often use it is it's a good prediction of how somebody is going to respond during IVF treatment. The more eggs that somebody has in the ovary, the more eggs that will grow and can be retrieved during an IVF cycle. So it's useful for counseling in that way too. And then again, the semen analysis is done for the male partner. This is pretty simple. This can be done. Actually, most men will just collect this at home in a cup, sterile cup, and then bring it in, drop it off in the office, and we look at it under the microscope. We're counting just the number of sperm that we see. That's the concentration, the motility, how many of them are normal, moving around, and the morphology, how many look completely perfectly normal. And these are sort of the typical thresholds, the typical parameters. So anything at or above these levels overall is normal and what we expect to see. These numbers start to get significantly below these thresholds. The lower and lower they are, and the more abnormalities that we see, the higher chance that there's a sperm issue that's contributing to the infertility that needs to be addressed. And so ultimately, once this evaluation is done, you see the pie chart here that shows you the breakdown of the results. It's actually kind of a fairly even split. About a third of the time we find there's some female factor that's contributing or causing the infertility. About a third of the time we see that there's a male factor, there's an issue with the sperm. And the other third of the time it's a combination of the two, or sometimes everything is perfectly normal. We call that unexplained infertility, and that's relatively common as well. In those cases, it's probably something a little bit more subtle related to the health of the sperm or the egg that might be making it a little more difficult to conceive. With the female infertility, these are some of the more common causes. Age-related is a big one. Many of my patients in their late 30s, early 40s, everything is normal on the testing. It's an egg quality issue. At that point, a lot of the eggs they're ovulating are not normal, not healthy eggs, so they're having a difficult time getting it just right. Or anovulation, patients with PCOS or some other conditions aren't releasing eggs regularly. These are the patients that have irregular cycles or no periods. These are the ones that are also important to come, see us as soon as they're ready to start trying to conceive. Or of course, issues with the tubes, the uterus, or endometriosis, another common GYN condition. We see that in about a third of women. And sometimes that can cause scarring. Sometimes that can cause a little inflammation that can reduce fertility a little bit as well. Once this evaluation is complete, the next step, of course, is to meet and review those options, and then talk about, what treatment is available and what that's going to look like. And I always explain to patients that there's, not a clear, right and wrong way to proceed once a fertility evaluation is completed. Reproductive health, family building is such a personalized decision. It's such an individualized decision that the important thing, and my job is just to identify any major barriers and then to educate you on what your options are moving forward, what the success rates are with that, what the risks are, what the benefits are. And then from there, as an individual or as a couple, you'll talk, you'll decide what makes the most sense for your family building goals and for, what your preferences might be. But, generally speaking, these are kind of the three, main options for somebody that's completed the fertility evaluation. Number one, of course, there's an option to do no treatment, continue to try, on your own. The success rates trying on your own are very, specific, related to the age of the female. Obviously, as age increases, these rates go down a little bit. But for example, for somebody that's less than 35 years old, when they first start trying to conceive, each month's about a 15 to 20% chance of a pregnancy. But the most fertile couples are usually going to get pregnant in the first 3 to 6 months. So those that are still, unsuccessful and haven't had a pregnancy after about a year, at that point, the success rates, that tells us that there's something going on that's making it more difficult. Success rates are quite low when somebody is at that level or at that point on the journey. So it's about a 1 to 2% chance of a pregnancy each month after the infertility diagnosis is made. So then, the interventions become kind of what we often refer to as like the simpler or sort of low tech treatment. And that's the ovulation induction. Sometimes we pair that with something called an IUI, intrauterine insemination. Sometimes that's just done with timed intercourse at home, or then kind of the more advanced treatment, the IVF treatment, a little bit more involved with the trade-off of having much higher success rates. With the ovulation induction, what we're trying to do is to stimulate one follicle to grow for that egg to be released. That's usually in patients that are not ovulating, like with PCOS, or patients that do ovulate that have infertility. A lot of times the goal is to get maybe 2 or 3 eggs to grow and release to increase the chance of some, another healthy egg, being fertilized. This is one where we use a oral medication, a pill that's called 2 different brands that we use, either Clomid or letrozole for different reasons. It's a pill that's taken for about 5 days. And then at the time of ovulation, the patient has intercourse at home, or we do an IUI, where we take the sperm, we take the high quality motile sperm that day, we concentrate it into a small volume, and then just deposit it inside the uterus to sort of give it a head start. When somebody has intercourse on their own, there's a few thousand sperm that ultimately get through the uterus into the fallopian tubes. When we do the IUI procedure, we can usually get a few million sperm up there. So we're kind of giving the sperm a little bit of a head start. And so that's one of the ways that this can be successful. This treatment option, again, depends on somebody's age, but usually we're boosting the success rate back up to where it was when that person first started trying. So somebody less than 35 years old, success rates with this often are around 15% per cycle. Somebody in the 35 to 40 range drops, closer to 10%. At age 40 and above, 5%, and then, kind of lower and lower as age increases. And so with that treatment, we're usually planning to do a few months in a row, because 15% success rate means 85% chance that it's not successful. So we plan to do a few months until somebody's pregnant, or after a few months, we'll check back in, kind of see how things are going, and then decide if we need to make any changes to the plan. And then the alternative treatment is the IVF. The goal here is to get as many eggs out as we can, safely. And in a ideal world situation, I would take 1,000 eggs from somebody's ovary and create embryos. They would have an endless number, of embryos that they might need. But the way the physiology works, that's not possible. Generally, we might be getting, somewhere between 10 to 15 eggs out of an ovary if somebody has normal ovarian reserve. Sometimes we get a few more than that. Sometimes we get a little bit less than that. But with those eggs, we then, in our lab, in the embryology lab, we fertilize those with the sperm, and then we grow those embryos out for about a week. The success rate with IVF strongly, again, depends on the age, but then also the ovarian reserve, the number of eggs, because that predicts, again, how many we retrieve and how many, embryos ultimately develop. And so success rates with IVF cycles can be, as for young patients, as high as 80+%. And obviously success rates decline from there, depending on the evaluation. So just to kind of give you a little bit more of an in-depth overview of what these treatments look like, this is the ovulation induction with the IUI. When the patient has a period, they come in for blood work. We'll look at the ovaries too, sometimes on ultrasound, see all these small follicles. After taking the Clomid or letrozole for 5 days, we come back a few days later, look at the ovary, and we'll see the follicle, is starting to grow. And we're waiting for it to get a certain size. That tells us that that egg is ready to fertilize. And then we give one injection, one medication to allow the follicle to ovulate and rupture and release that egg. And then again, either intercourse or the IUI. This is just what the IUI procedure looks like. It's kind of like a pap smear, just a speculum exam where we take the sperm, a little catheter that's threaded kind of through the cervix, just deposited inside the uterus there. Patient goes home a few minutes later, goes back to your normal activities. So it's like I said, it's pretty simple. It's pretty straightforward treatment. I've got my mouse on the wrong screen. Oh, this is what I was trying to show, just the catheter here being threaded into the uterus there. With IVF, again, a little bit more involved. This is sort of the timeline, but it's about 2 weeks, about 12 days of injections. And then the other big difference is that it requires a procedure with anesthesia, in order for us to retrieve the eggs. The procedure itself is actually very simple, very straightforward, but we use a needle, to go into the ovary, which is uncomfortable. So you get anesthesia for that reason. You're asleep and comfortable for this, but the procedure is quick. It takes about 10 minutes. And then again, about a week to grow the eggs out. And this is just what that procedure looks like. So it's all done vaginally. I think it's important to know. Just use the same vaginal ultrasound probe with a small needle on top. And on the ultrasound here, that needle is guided. This is kind of showing the needle as it gets into the ovary, into the follicle here. And then that's done for both ovaries to remove as many eggs as we can. Once those eggs are retrieved, our embryologist looks at them under the microscope. This is what an egg looks like. This is another egg. And then we'll fertilize it. We'll either put a bunch of sperm around the egg, and that's what all these little dark spots are here, competing to fertilize the egg on its own. Or we do a procedure called ICSI, where we select what we think is the best looking sperm under the microscope. And then using a needle, we just inject that into the egg and fertilize it that way. We get about 70 to 80% of eggs to fertilize successfully with these methods. And then the embryos are cultured in the lab for about a week. And this is just what an embryo looks like. I just think it's kind of interesting to look at if you've never seen it before. This is what the embryo looks like the first day after it's fertilized. And then you can see as the cells divide, there's more and more cells. On day 3, there's usually about 8 total cells. Each of these circles is a cell. By day 4 and 5, now there's dozens of cells, up to about 100 cells on day 5. And this is the embryo that we're hoping to see by that point in time. Any embryos that are created, are frozen and then available to use in the future. Sometimes a patient ends up with extra embryos. We might get 3 or 4 usable embryos, which is nice too, because then we can transfer one embryo, try to help somebody get pregnant. And then if there's extra embryos, those just stay frozen. And then the patient might come back to use those for another pregnancy in the future. Before we freeze the embryos, sometimes we do a procedure called pre-implantation genetic testing, or PGT, where we actually remove just a few cells from the embryo, and then we freeze it, and then we send those cells off for genetic testing. That's these cells here being removed. And so this can be done to screen the number of chromosomes that an embryo has, to try to identify, which embryos are missing or have extra DNA. Those are ones that are not going to implant, or they're not going to be healthy pregnancies. So we don't want to use those. The ones that come back with a normal number of chromosomes, those are the ones that are, potentially going to be the successful embryos. Those embryos usually have about a 50 to 60% chance of a live birth. And so these are the ones we then will select and transfer to the uterus. And this is what the embryo transfer procedure looks like. It's actually relatively simple as well, not all that different from an IUI. This is the uterus here. This is the catheter, this white line, and you'll see, you already saw it at the tip here, a little flash right there. That's a little fluid with the embryo in. So the embryo is deposited there, and that's pretty much all there is to it. So this embryo transfer similarly is relatively straightforward. Okay, so that's I think fertility in a nutshell, and the overview that I wanted to go over. I'm just going to briefly talk about my practice here, RMA of New York, and then I'll see what questions you guys have. Anything you want me to talk more specifically about them, I'm happy to do that. I think it's when you are thinking about having a fertility evaluation or being seen at a fertility center, there's a few different things that are really important to think about. One of them just kind of being the reputation of the clinic and how long they've been doing what they do. This is very, very complex science required with fertility treatments. Of course, the physician that you see and their experience and how you guys work together is a really important relationship. But on the other end of it, there's the embryology lab, which is such a critical component. I could never be successful if I didn't have an amazing, embryology team here in the office 7 days a week. Helping and managing, the eggs and the embryos and doing all the critical, micro manipulation work that they do. And so that's one of the, I think, most impressive and incredible things about our team here is the success rates that we have based on, how our team works together. So we've been around in New York for over 20 years. With over 25,000 babies born. So lots of incredible patients that have come through, and we've got to be a part of a lot of really wonderful success stories. And we're affiliated with the Mount Sinai Hospital on the Upper East Side. And so we work closely with a lot of those physicians as well. But fertility treatment, often you're in the office during these treatments for visits, sometimes a few times a week. And so access is one of the most important things, which we certainly recognize that. And so we're constantly looking for places where we can, expand and open up another location to help make life a little bit easier for our patients to get in for ultrasound or a blood work visit. But these are just, a lot of the locations that our offices can be found in Manhattan, on the east side, on the west side, down in Soho, out in Brooklyn, but then out in Long Island as well, up in Westchester. So we've got offices all over, and certainly, patients kind of move around between offices. Sometimes I have patients that maybe live out in Brooklyn. They'll see me for a visit on the east side, but then they might go to that office for blood work and ultrasound, or maybe they're working in the city in one day, so they come to see me. But this just makes life a little bit easier to have so much access, which I think really helps as somebody's going through treatment. And then the last thing, like I said earlier, to think about is just the success rate and the track record for a particular clinic. A lot of people don't know that this is publicly available information, that it is sort of mandated that fertility clinics report. And so we report that to an organization called SART. And that can be found online, where you can look up, success rates from a clinic and see, how many cycles is a clinic doing? What is their experience? What is their volume? And what are their actual outcomes look like for a patient like me? You can look at age and other factors there. And I think that's a really helpful thing that I usually encourage folks to look at as they're trying to decide where they want to do their treatment. Obviously, getting recommendations from your physicians, from your friends or former patients is always a really great way to find a good clinic. And then, many people, it's important to look into your insurance. A lot of people have coverage for treatments that you might not realize. So you want to find a clinic where, obviously they accept your insurance or they're a preferred provider for your insurance. And here at RMA, we accept all major insurances, and we have each team as a financial counselor that helps the patients walk through what their benefits are, what their coverage looks like. And I think that's a really helpful service that we provide, because navigating insurance is a nightmare, to say the least, for anybody, for any kind of treatment. And so to have somebody available to help look at that, I think is super helpful. So anyways, that is all I have for you guys. So thank you for your attention. And I want to, like I said, I'm going to look and see what questions we have here. So I think I need to stop sharing my screen. But I just put up some contact information here. This is our phone number, of course, for the office. So if you're interested in making an appointment, or you need to make a new visit or follow-up visit, you feel free to give us a call. I would love to meet with you and talk to you more about your specific history and answer any questions that you have. but you can call and schedule an appointment with any of our physicians here. And then I put my personal email on here as well, just in case you have any follow-up questions from today. Sometimes folks have, real specific questions that relates to them, that they want to go through, and you can feel free to reach out to me if there's anything that I might be able to help with. So with that, I will stop sharing the screen here and pulling up the question and answer box to see what questions have come through. So feel free to add anything here, and we'll go through it. So, all right. So the first question in the box here says, how many eggs or embryos might be needed to achieve 2 successful pregnancies through IVF treatment? So, this is a great question. This kind of gets at when we're planning a treatment cycle, we think about what somebody's family building goals are. So I always want to know, how many children do you want to have? What is your priority? For some people, they've had such a difficult time to even get pregnant that all they want to focus on is just getting pregnant now. I just want to have one child, and then we'll kind of figure out the rest later. Other times people come a little bit earlier in the journey, and the focus really is, well, we really want to have 2, or we really want to have 3 children that are all genetically related. And so we know the younger we do this treatment, the more success we're going to have. So we want to plan all of our treatment now so that we've got embryos to transfer now and down the road. So when we're focusing on one child, if somebody's going through IVF, we wait, we see how many embryos are there, and if there's at least one usable embryo, then the next next treatment is going to be transferring that embryo to try to get pregnant. But if we're doing planning for multiple children, that's when we talk about what's called embryo banking, where we'll start with one cycle, but maybe we'll do more than one until we get enough embryos that we think somebody can have 2 or 3 children successfully. And so I usually recommend, with a 50 to 60% live birth rate, per embryo, about 2 euploid, 2 normal embryos per desired child. So if somebody tells me they want a family of 2 children, then in an ideal world, 4 usable embryos it would be very, very high chance of being successful in that way. Sometimes that plan changes along the way. Sometimes we're having a more difficult time getting usable embryos than we thought. Or somebody's gone through a cycle and it took a little bit more out of them emotionally or physically than they thought it might. And then we decide maybe we'll start transferring embryos a little bit sooner. And then again, we'll come back to this in the future if we need to. But for two successful children, I would recommend banking, 4 usable embryos. So, okay, another question would be, is there ever a time somebody might not be a good, fit for fertility treatment care? And if so, what would some reasons be, in terms of evaluation? And there's a question kind of about low AMH. So it's hard for me to think of a time where I would say somebody is not a fit to be seen, for fertility evaluation. Even for patients that I don't think treatment is a good idea, or I might recommend, a different option. I think just the initial conversation, I mean, we spend so much time going through history. We spend so much time just educating about the reproductive process, answering lots of questions, kind of breaking a lot of myths down, that I can hardly think of a single scenario where I would say that a patient is not a good fit. I'm always happy to meet and see any patient, even if ultimately that prognosis is very low based on maybe somebody's age, their ovarian reserve. I think it's really important for that person to really understand what their success rates are and what their alternative, treatment options might be. Because again, my job is really just to educate you, to help you understand how you can build your family, what the most successful options are going to be, what some alternative options are going to be, to then help, that person sort of make those individualized decisions about how they want to proceed. So there's hardly a time where I wouldn't want to meet with somebody to talk more with them and answer questions that they have. Okay, another question here. This is actually a really common one I get about doing treatment. This is about like an IUI treatment, but this is true for IVF too. If you're doing multiple cycles, can you do them sort of back-to-back months, or do you need to take a break off? Do you need to take time off in between? So, for IUI, and for really for IVF or egg freezing is where this comes up a lot. There's no difference in success rates if we're doing back-to-back treatments or if we're taking time off. This is something that we presented actually at our national conference last year, some of our data on this particular question. But I always leave it up to the individual patient. Once somebody's in a treatment cycle, a lot of times they're kind of in the groove of everything. They want to keep things rolling. If that first IUI successful, treatment's not successful, then usually they'll come right back in, a couple days later with their period, and then we'll start, the next treatment cycle. And so success rates are great that way. There's no medical reason to take time off. That being said, I always, put the caveat out there that going through this type of treatment sometimes is not very easy. Again, it can be, demanding emotionally and physically, and sometimes patients just need a break. So, we take it one cycle at a time. And if somebody ever feels like they just need some time, they need to take a month off, to kind of focus on themselves, to focus on, their relationship or whatever it might be, then, I certainly always encourage that. There was another research study that I did during COVID where I looked at patients that had to take breaks because of COVID and what impact that had, 1, 2, 3 month break on treatment. And ultimately, what I observed was that success rates are the same in that short period of time. So if somebody starts treatment now or starts treatment 2 or 3 months from now, that there's not a clinically significant change in the outcome. We're going to see the same thing. Of course, over time, if somebody's delaying 6 months, 12 months, now we might see a decline in egg quality or quantity. But if somebody needs time off in between cycles, then absolutely that's a reasonable thing to do. But if you're in the groove and need to keep going, multiple months in a row, then medically that's a safe and successful thing to do. Okay, so then the one more question here, a specific question about somebody who's done treatment and looks like created some embryos, but ultimately did not have success with those embryos. And the question is about what would success rates look like if they tried to do another cycle. So with these questions, I mean it's the perfect question, exactly what you should be asking. I think the important thing would be to connect with your physician and based on your history, they really should be able to give you a very good understanding of what those success rates would look like. We have different predictive models that we can use, modeling our sort of decades of retrospective data, where I can put your age, your ovarian reserve, your other evaluation into that model and give you a good idea of what success rates look like. Generally, if somebody's done one treatment cycle that wasn't successful, the success rate in the subsequent cycle is relatively comparable. So if your chance of live birth was, let's say, 30% when you started that first cycle, with the second cycle, it's going to be about 30% again. Over time, similar to people that have infertility trying that on their own, as we see, cycles that are not successful, then those success rates might start to decline a little bit. But to get a very specific, number, that's definitely a great conversation to have with your treating physician, and they should really be able to help you understand that a little bit further. Okay, and then I think it looks like one more question here. So the question here is about therapy, group therapy for patients, and mental health support, which is an incredible question, and I appreciate you asking that. And I should have mentioned that earlier. I think that's a incredibly powerful thing that I recommend to all patients to think about. To be mindful of if at any point, the stress or anxiety of the, excuse me, of the, situation is you're starting to feel, then sometimes talking with a therapist, somebody experienced in reproductive health or perhaps pregnancy loss is very, very, very beneficial. I've seen tons and tons of success for patients, meeting with therapists. And so we do offer some different options here at RMA, depending on a patient's individual needs. So we have a social worker that works with us who is incredible and works with a lot of our patients, depending on certain issues that they might be having. She's an incredible support. We also have a psychiatrist who has decades of experience, and works with and counsels a lot of our patients, particularly those doing third-party reproduction, using donor egg and things like that. And then in the community, there are a handful of other therapists that we work with closely. There is actually a really successful group therapy that's run by a psychoanalyst named Golzar down in Soho, in a group called Downtown Women's. So I actually do send some patients down there specifically for group therapy. And I hear all kinds of great success stories. It's incredibly powerful. This is done during pregnancy for some patients as well, to be a part of a community of people going through similar situations. Sometimes these things are things that you don't feel comfortable talking about, or people just don't talk about. And so being in a community where it's encouraged to discuss your successes and your challenges and your setbacks is very powerful. And so this is definitely something that I would recommend. And if you're a patient here, we can certainly give you a list of other providers that we would recommend. Or if you're patient somewhere else, I'm sure they could help connect you with those resources. But absolutely, I would encourage that for anybody. Okay. All right. Well, that's all the questions that we have. So hopefully we were able to answer everything today. But I want to wrap up, and before doing so, just again, thank you all for joining me and spending your evening learning a little bit more about fertility. I certainly hope that this was helpful for you, and I hope you took something away from it. But if there's anything more that I can do to help, please just reach out. You have my email. You can always give us a call here to schedule a time to meet with me, and I would love to talk with you more. But I wish you all the best on your fertility journey. Take care.